Hi, this is Dr. Anjali Pal here. Today we're going to talk in brief about hair disorders and common questions you'll get. I'll quickly talk about examination of hair so that you can understand the questions later. Okay? You'll first look at the quality of the hair and the quantity of hair. Now this is both on the scalp as well as the face and the body, right? This can give you some clues of whether it could be alopecia areata or whether it could be due to a thyroid disorder. Okay, whether it could be due to chemotherapy or just patterned hair loss. A hair pull test is then done. It's a simple clinical test in which you choose around 60 hair on the scalp around the vertex and you do it to check if there's excessive active hair shedding. So there's active hair shedding when there's more than 10% of hair that is removed. So out of 60, if there are 6 hair which come out loose, it means it's a positive hair pull test. Okay, there's active hair shedding going on. You'll then look at the scalp alopecia. Is it localized or is it diffuse? So in localized alopecia, you'll see if there's a well-defined round patch as an alopecia areata. You'll do a hair pull test to check if there's active hair shedding. Look closely with a magnifying glass or a dermoscope and see if there are tapered hair or exclamation mark hair. That's a clue for alopecia areata. Look for scarring or the lack of scarring. So in scarring alopecia, you will not see follicular orifices, which are seen as pinpoint dots on the scalp. That's a normal scalp will have follicular orifices. An alopecia which has led to scarring will have fibrosis, so you will not see the follicular orifices. And you will sometimes look for tufted hair. So that's in certain types of scarring alopecia. You'll have like doll's hair, tufts of hair left behind. Diffuse alopecia can also exist. So that could be either due to a thyroid disorder or patterned alopecia, which is the most common kind of alopecia. So here are some photos for you to just identify. The first is localized alopecia areata. So it's a well-defined patch of non-scarring alopecia. When you look closely, you will be able to see the follicular orifices. The next is scarring alopecia. So you can see there's erythema. So there's been some inflammation and there is fibrosis on that scalp over there. And it's like footprints in the snow. This is a classic appearance of a fibrosing alopecia at the end stage. Okay. Tufted folliculitis is the third photo in which you can see the hair looks like doll's hair. So there are tufts of hair which have come out from one and there's fibrosis in between. Okay. The photo down below shows pattern balding in a female. That is female pattern hair loss. Okay. This is in advanced age. And the last photo here is showing a diffuse type of alopecia areata. Okay, after looking at the hair, you also look at the scalp skin. That's very important. So common findings would be erythema, that's redness. So it could be either diffuse across the whole scalp, could be patchy in parts, or it could be around the hair follicles. Okay, that's a clue to inflammation of the scalp skin. The next is flaking and scaling. So again, this could be diffuse, like in sometimes seborrheic dermatitis, could be patchy, like in a patch of psoriasis of the scalp, or it could be follicular as well, which could be both in psoriasis and in seborrheic dermatitis. It could also, a follicular scaling and flaking can also be seen in lichen planopilaris. Okay. So there could be papules or pustules. These can also be follicular or non-follicular. You look at the hair shaft, whether there's been a hair cast surrounding the hair shaft. You look for nits, especially on the occiput. Okay, that is the louse egg case, the empty egg cases. And you look for excoriations as well. That's an indication that there's been severe pruritus. So here you can see a thick scaling. This is silvery kind of thick scaling which goes up along the hair shaft. The first photo. And the second, you can see a perifollicular erythema. Okay, common types of hair loss. So you can have anagen effluvium. This is when the hair is shed during the growth phase or the anagen phase. This is seen in severe illness like autoimmune disease, cytotoxic chemotherapy, or loose anagen syndrome, which is a genetic disorder. It's not as common as the next type of hair loss, which is called telogen effluvium. So telogen effluvium occurs 2 to 6 months after the event, after the triggering event. It's approximately 3 months after a triggering event that stops the active hair growth. So the hair, basically what happens is there is some stress trigger that jumpstarts and shifts the growing hair from anagen into telogen phase. And telogen phase lasts 3 months. So after that 3 months, so it switches from anagen immediately into telogen. After the 3 months, it is then shed. So there's like an accelerated shedding of hair. This can occur commonly after delivery. Any type of fever, really, especially COVID in the last 2 years, we've noticed a lot of telogen effluvium after COVID. Severe weight loss, so crash dieting, is a very common cause. Severe hemorrhage, any surgery, any illness, or even psychological stress, as well as consumption of medicines, can cause telogen effluvium. Now, the most common is the genetic type of hair loss, which is called patterned hair loss, or male pattern hair loss and female pattern hair loss. So this is essentially genetic, and very commonly known that 50% of individuals by the age of 50 will have evident patterned hair loss, and in India it's probably more. So in male pattern, you can see it starts from the temporal sides and the frontal recession, which goes back, as well as there will be clearing in the vertex, and then these two portions meet, and then that leads to advanced pattern hair loss, as you can see in the male's photo. In the female, you'll typically have thinning on the vertex. You will also have temporal recession, so it will usually, this is very advanced female balding, in which you will see a bald patch in front. Common cause of non-scarring alopecia. This is important to remember. So most common is alopecia areata, tinea capitis, psoriasis, and seborrheic dermatitis. Later we have systemic illnesses, so systemic lupus erythematosus, thyroid disorders, iron deficiency anemia, and chronic illness. So here are some photos again for you to identify alopecia areata, well-defined circular patch of hair loss, non-scarring. In psoriasis, usually you will see it at the hair margin. So you can see this is the occiput, this is the back of the ear, in which the skin is also involved, and you can see the silvery micaceous scales with underlying erythema. So that's classical of psoriasis. And down here you have the yellowish thick crust, which is typically seen in seborrheic dermatitis. Seborrheic dermatitis can occur anywhere on the scalp, can occur on the occiput or the vertex. Causes of scarring alopecia. So these are important to remember. The first is, of course, you have trauma to the scalp, which removes tissue up to the subcutaneous. You can have scarring alopecia. Any surgery or radiation, of course. Traction alopecia. So traction alopecia is when there's a constant tug. Example, when you have a very tight ponytail, or even when in sardars, when they have that constant traction when they're wearing a pagdi. So you can see by the late teenage years, they've already developed a lot of traction alopecia from the sides. Infections, bacterial, fungal. Remember the types of tinea capitis that can cause scarring alopecia would be Favus and Chirion. Those are the very inflammatory type of fungi. So they can destroy the roots. And viral is herpes zoster. Now, these specific inflammatory skin disorders which cause scarring alopecia are important to remember, though they don't seem very familiar to you. So most important, lichen planopilaris, discoid lupus erythematosus, folliculitis decalvans, dissecting cellulitis, frontal fibrosing alopecia, and pseudopelade of Brock. So something in all these names does give you a clue that there is some amount of scarring. So that's an easy way to remember that. These are types of scarring alopecia. So here you have traction alopecia with a tight ponytail and dreadlocks. Up here again you have folliculitis decalvans, which ends up with fibrosis and doll's hair or tufted hair appearance. Looking at the photos below, so discoid lupus erythematosus will have a scarring, And lichen planopilaris will typically have this perifollicular scaling and erythema and scarring alopecia, as you can see here. Okay, so starting with some questions. Which of the following conditions causes alopecia without scarring? So we've discussed this already. Discoid lupus erythematosus, herpes zoster, alopecia areata, and lichen planopilaris. So I think you should know the answer by now. It's alopecia areata. A child presenting with localized patches of complete hair loss with normal appearance of scalp. What is the diagnosis? So again, this is an easy question. Could it be tinea capitis, cradle cap or infantile seborrheic dermatitis, alopecia areata, or telogen effluvium? So localized, well-defined patch of hair loss, normal appearing scalp is characteristic of alopecia areata. Tinea capitis, you would have some scaling and you could have pustules. You would do a KOH smear or a KOH mount of the scales of the pustules, and you could culture it as well. In infantile seborrheic dermatitis, there's no clear-cut hair loss, but you'll have yellowish, greasy scales. And in telogen effluvium, there's no localized patch of hair loss. There's a diffuse hair loss. There's more than 100 hair loss per day. So the answer is alopecia areata. Patchy hair loss with hyperhidrosis of skin points to a diagnosis of. Now this seems to be a very vague description. So we could just narrow it down. So, patchy hair loss with hyperhidrosis. Not typical of alopecia areata. It's a well-defined hair loss. Trichotillomania would usually, you would have to elicit a history of constant tugging or some sort of stress in the patient, which leads to tugging of hair from a certain part. A hypothyroidism does fit the description. Anagen effluvium again does not fit that description. So the best answer here would be hypothyroidism. Exclamation mark sign is a feature of telogen effluvium, androgenetic alopecia, alopecia areata, and alopecia mucinosa. So of all these, the answer is alopecia areata. So it's essentially an autoimmune disorder in which the T cells attack the hair follicles, right? So there's no symptom really besides sudden, well-circumscribed patch of hair loss that is noticed by the patient, okay? Could be just a few days ago, it could be a couple of months. Sometimes the barber notices the patch of hair loss, patient does not notice. It can be associated with vitiligo and autoimmune thyroid disease because it is autoimmune, so remember that. Sometimes associated with atopic eczema as well. The nails can be involved. This is just for the MCQ purpose. You may have pitting, uniform pitting on all the nails. You may have tracheonychia, which means rough nails, or you may have onycholysis, which is separation of the nail bed from the nail plate, okay, distally. It can affect any part of the body. Alopecia areata can affect commonly, besides the scalp, it can affect the eyebrows and the eyelashes. Okay, but this can also extend to the whole body, where it's called alopecia universalis. And when there's regrowth, quite commonly we have white hair that is grown back in the patch. Okay, so sometimes it's described as turning white overnight, because when the hair grows back, it may be white. There's loss of pigment in the hair follicle. Exclamation mark hair is an important point to note for when you're looking through trichoscopy or dermoscopy on the scalp. Okay, a female presents with diffuse hair loss, excessive hair fall more than 300 strands per day. She has had typhoid fever 2 months ago. What is the diagnosis? So here the most fitting diagnosis would be telogen effluvium. Okay, fits all the characteristics. Androgenetic alopecia would be over a very long period of time. There would just be diffuse thinning of hair. You wouldn't necessarily notice excessive hair fall, would not be over a short duration, takes years. Alopecia areata, there is again localized hair loss. And anagen effluvium, you would have a history of something like chemotherapy or a very severe illness like an autoimmune disease, or something like a childhood congenital disorder like loose anagen syndrome. Alopecia areata is not associated with exclamation mark hair, atopy, pitting of nails, or geographical tongue. So I've explained to you in brief what alopecia areata is. Answer is geographical tongue. Anagen effluvium is induced by all except radiation therapy, protein allergy, malnutrition, anti-cancer drugs, or prolonged labor. So the answer here is prolonged labor because that is classical of telogen effluvium, right? A stressor precipitating excessive hair fall 3 months later. All are causes of cicatrizing or scarring alopecia except lichen planus, DLE, chirion, or alopecia areata. So again, the answer should be clear by now. The answer is alopecia areata. Telogen phase of hair cycle lasts for 3 weeks, 6 weeks, 3 months, or 3 years. So the telogen phase of the hair cycle I just mentioned was about 3 months. So let's just take a look at the hair growth cycle. So the anagen is the growing phase. This varies. It can be from 2 to 6 years, depends on the different hair on your body. So things like eyebrow and eyelash hair have a shorter anagen phase, but the hair on the scalp can typically last from 2 to 6 years. Okay, and that determines your hair length as well. Okay, this is genetically determined. Now the catagen phase is a regression phase, and then after a short catagen phase of around 3 weeks, you have a telogen phase, which is the resting phase. The hair bulb contracts, becomes club shaped, and this lasts for around 3 months, after which the old hair is shed off and again the new anagen phase starts. Huxley and Henle layers are part of the skin, nail, hair, or sweat glands. So of course we're talking hair, so this is part of the hair. I'll show you the layers so that you can just understand. So the this is the dermal papilla cells. You have the inner medulla. The yellow is the hair cortex, and then the cuticle surrounding that. Outside that, you have the inner root hair sheath. You have the Huxley layer, which is inside, and the Henle layer, which is outside. So I just remember it as Henle. It should be inside, but it's outside, and Huxley, X is, later in the alphabet, so it's outside, but it's inside. It's just the opposite, completely opposite. So Huxley layer inside, Henle layer outside. That's it. There's no other way to remember it really for me. Outer root sheath, and then in red here is the hair matrix amplifying cells and the dermal sheath cells. So that's briefly it about hair. I don't think you need to know more details about hair. That should be enough.